My name is Dr. Andrea Shaw, and this is a VAP on infant botulism. And these are the learning objectives that I hope to convey through this short segment. Number 1 is define infant botulism, understand the pathophysiology of the condition, recognize clinical features of infant botulism, and be familiar with the management strategies and prognosis. As a definition, infant botulism is a condition caused by a toxin released by Clostridium botulinum spores that may colonize the large intestine of a young infant. Infants between 1 week and 12 months of age are at risk, the median age being 3 to 4 months. Clostridium botulinum are soil organisms that exist as spores that may be consumed or found to contaminate certain foods, such as honey and home canned foods. Spores release botulinum toxin, which causes a blockade of the neuromuscular junction, causing bulbar dysfunction, weakness, and respiratory failure. The pathophysiology of the condition starts with the Clostridium spores. The botulinum spores are ingested. They colonize the large intestine, where they release botulinum neurotoxin. The neurotoxin blocks the neuromuscular junctions of skeletal and smooth muscles. Initially, smooth muscle of the colon is affected, followed by progression to bulbar muscles and flaccid paralysis. This is predominantly a motor paralysis, as the botulinum toxin does not cross the blood-brain barrier. So with no central nervous system involvement, you can expect normal sensation, perception, and sensation in the setting of motor paralysis. The clinical presentation may vary from mild to severe. This is likely due to variations in the bacterial inoculum and host susceptibility. Initially, the infant may present with constipation. This is a nonspecific finding, but when it's followed by poor feeding, your antennas should raise for this condition. This may present as a poor suck from a breastfeeding infant, where the mother finds herself engorged because the infant's not feeding as much. The progression to weakness is concerning, where bulbar difficulties will present with feeding difficulties and drooling. You'll see a descending paralysis and global hypotonia. The baby will present with anorexia, irritability, lethargy, and a weak cry. On physical exam, when holding the baby upright, you may notice ptosis. You may see a blunted facial expression, dilated or sluggishly reactive pupils, a slightly disconjugate gaze, poor head control, drooling or pooling of their saliva, a weak cry, diminished suck or gag reflexes, decreased sphincter tone, hypotonia and generalized weakness, or a decrease in deep tendon reflexes may or may not be noticed. Suspicious history coupled with any of these clinical findings should prompt urgent hospitalization to monitor for respiratory failure. Then diagnostic investigations might include serum or stool studies. Serum studies for botulinum toxin have very low sensitivity, and it's not recommended to be worthwhile to obtain. Stool samples that isolate the Clostridium botulinum spores and botulinum toxin are much more sensitive, but these investigations are not timely and may take up to a week for you to obtain the results. If the clinical syndrome is suspicious, go ahead and send the stool studies, but pursue electrophysiologic studies and empirically treat. Electromyography, or EMG, findings will support the diagnosis when it shows repetitive nerve stimulation with an abnormal incremental response. Management is largely medical. It's something that should be treated as soon as possible, and there's no need to wait for the confirmatory tests if your clinical suspicion tells you otherwise. The treatment is botulism immune globulin, It's a human-derived botulism antitoxin antibody, also known as Big IV or Baby Big. It's purified immunoglobulin, IgG, that's obtained from pooled adult plasma from persons immunized with the pentavalent botulinum toxoid who demonstrate high titers of antibodies. Early treatment with botulism immune globulin has been shown to reduce duration of ICU stay, mechanical ventilation, supplementary feeding, and overall hospital stays. The important thing is not to administer antibiotics unless there's specific secondary infections you're treating. Aminoglycosides are found to be contraindicated, and anticlostridial agents may increase the risk of further toxin release. The management is largely supportive from a respiratory and feeding standpoint. Respiratory positioning is a key aspect of the respiratory management. Placing the infant on a firm mattress at a 30-degree angle with a neck support in place will assist with their natural respiratory mechanics. Half of all patients with infant botulism will need mechanical ventilatory support for respiratory insufficiency or inability to protect their airway. From a feeding standpoint, nutrition is essential. They typically tolerate enteral feeds well despite the slow gut motility. Resumption of normal defecation is desirable in order to eliminate the Clostridium botulinum spores and decrease the toxin burden. It's important to monitor stools, as patients may need stool softeners in combination with the enteral feedings in order to promote restoration of normal defecation. Prognosis. Progressive weakness will often nadir at approximately 1 to 2 weeks. The illness may last 1 to 2 months and take months after that for full recovery. Morbidity and mortality from this condition are largely related to secondary infections, often found with middle ear infections, lung infections, urinary tract infections, or secondary intestinal infections. This is the sequelae of prolonged mechanical ventilation and hospitalization. Because there is no central nervous system involvement, there's full potential for normal intelligence. Motor milestones will ultimately catch up after full recovery. In summary, infant botulism can affect infants 1 week to 12 months of age, where Clostridium botulinum spores are ingested and release neurotoxin from their large intestine. Clinical features result from progressive neuromuscular blockade, ranging from mild to severe. Initial presentation of constipation is often followed by bulbar weakness and an acute progression to weakness of the trunk, extremities, and diaphragm. History and exam concerning for infant botulism should support urgent admission given the risk for respiratory failure. Consideration of treatment with botulism immune globulin is important to pursue without awaiting final confirmatory testing. The low risks of treatment are outweighed by optimal clinical improvement with earlier intervention. Here's a couple good articles for further reading.